input right, no change. No, that's fine, because the screen's up there. Oh, yeah, the audio. No, I use that audio. That's an HDMI. This looks completely fine. It's got to go somewhere to get the feed. Huh? I guess the other option. That is cool. That one. Just put a cross through every line that's... Well, why is it not working here? Because there's...
Take a line? Oh, yeah. Weird.
Okay. This is unfortunate. Okay, why would that do it? I don't get it.
You could maybe do one without an audio connector. If you're not going to use it anyway.
Okay, so this one I got to go through. The wonderful world to spend all your lab money on connectors to get in with this. This is a USB. Wait a minute. No. I don't have that conversion. That's a different one.
What about this?
No. See, I've got to get the connector in there. That's a straight USB, and that's FireWire or something.
Well, what about this?
Wait. The sound got shut off. Okay, we're okay. Hold on. I'll just go with this.
Wait, let's try it now.
I'll try this. Okay.
Right.
Let's see if this is loud.
Right.
Can you hear this?
Left. Right.
Can you hear?
Right.
No, from here?
Right.
Nothing?
Right.
This thing's not transmitting. What? Well, how about the lecture? Sometimes that's what I want to pick up. Hold it. Let's see, I've been through many miseries with these things in many places, in many countries. How about we do this?
Are we powwowing or
No, where the audio's not working. What else is new in life?
Yeah, right.
Okay. Let me get into this.
You don't have an HDMI.
I don't have my HDMI adapter.
There might be one in lab if I ran.
Just put a cross through every line that you see there. You can hear it now? Can you hear this?
Speakers on the side.
Do you think you're having trouble seeing things on the left side?
Oh,
Can you
yes.
hear this?
I
No?
have to,
Hello?
when I read, I have to make sure I
Can't hear
go
it.
all the way
Yes?
on the left side to start
She's saying no.
the line.
Yes?
Up slower.
Flour in a pot?
Is it all the way up? That's the leg turn.
I didn't do that very well.
Okay. Great. And
You can hear it?
what letter do
I
you
have
see
better
there?
hearing than you.
F.
It's high frequency drop off for me.
What letter do you see?
Okay, good. We got it. We're good.
Can you hear it now?
Left click, right click your phone. Ready?
Yes.
No, I got to play it through this because the
what
feed
I'm
from
saying.
here's not working.
Ready?
Yep.
Which means the whole audio feed for the talk is probably not working, but
Yeah.
Left click.
Okay.
bunch of idiots.
Right click.
Ready? Okay.
Right click.
It's
you can't hear anything right now? No?
Have both.
Okay.
Right,
Now, yeah.
right, right, left, right, right.
Not sure. Okay.
Left, right, left, right, 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 left, right, left, right.
Well, the thing is, it's not bad to get in front of every crowd.
I'm okay with it. I just don't know what else I'll think about it.
You're a Berkeley PhD student. You got a million things to talk about. You get paid for your ideas. Okay. What happened? Guys? Toke. It is one of those days. I'm sorry. All right. Okay, so the connectors finally won today, so the audio may be a little bit flaky. So Colin brought up a really interesting point in the last class that the insula, which is a huge part of the cortex, has been largely ignored. So what he's going to do is give you a view on what the function of this area, what's known about this area, what's not known, which is a lot more than what's known, and maybe some ways to approach this. Where's Colin? Are you third or fourth here? You're third, right? Fourth here.
Third and a half, third and
3.75? Okay. And he's in my lab. He does a lot of, he did it 2 years after college at the NIH, doing some really interesting neuroimaging, fMRI work. And now he's working on mainly intracranial physiology. So, Colin, it's all yours. No. That is not the way this game is played. Get up there. What? Yeah, everybody's going to do it. I just thought of that this morning. Okay. No, first you have to figure out what advances and reverses the slides.
Pointer, forwards, backwards. Should be. Right? Is your thing working? Are you plugged in? Really? You didn't plug me in?
It's an IQ test. Okay, let's see. There you go. All right. Oh, wait a minute. Sorry. Wire up. What?
Yeah. Thanks. Appreciate that. Yeah. All right. So the reason I brought it up last time, aside from giving him some flack, I can say flack, right? The insula is largely ignored by pretty much everybody, so it's not just this course. So does anybody know where the insula on this brain is? Anybody? Can you raise your hand? You should probably not raise your hand because you can't see the insula. This and the medial view of the brain are the commonly presented ones, and actually you can't see it because the insula is inside, right? If you were to lift up in the Sylvian fissure here, lift up the frontal lobe and the temporal lobe, then you see the insula buried in here, right? So it's still cortex, it's still got your gyri and sulci, but because it's underneath this, it's pretty much never displayed unless you intentionally will either lift apart or put some cut where you can see it. And so here's a post-mortem slice where the pathologist has actually cut away large parts of the temporal, parietal, and frontal lobes so that you can see the insula here. And most people, wouldn't know that it's ever there unless you go looking for it. And so that's actually been the case for a large part of the history here. Just to put in a little bit of context relative to some of the other regions that we've been talking about, I'm not sure that we've mentioned the limbic system as a term yet too much. But essentially, that is kind of an old vestigial term from some of the original sort of people in the field that thought about this kind of very old set of brain regions in terms of evolutionary lineage, going back to some of the very primitive mammals that include the insula, along with some regions that we have talked about. So in light green here, the cingulate cortex, and also the limbic system includes the amygdala and the hippocampus, and some of this orbitofrontal cortex. And so these are some regions that we have talked about, particularly recently in the context of emotion, which is why we brought it up last class. But the insula is all heavily interconnected with these regions. And as we know, they're heavily involved in emotion, motivation. Certainly the hippocampus is in there, so you've got learning and memory, and certainly about emotional events. You want to be able to learn about those and react to them appropriately. So it's definitely tied into the things that we've been talking about. But in terms of its specific function, one way that you could think about it is primary interoceptive cortex. So interoception is basically your sense of self and what's going on inside of your body, right? So like I said last time, it's not just, sight, sound, touch, taste, and olfaction, but you can feel pain and temperature and itch and all these things that are not necessarily just touch, right? You have different sensory receptors embedded in your skin, and those signals arrive in the insula after the going through the thalamus. And so one interesting note is that a lot of times these signals, we tend to think about them and we tend to talk about them, so use them in language in ways that are more closely connected to emotion, right? Oh, this is hot or cold, or ooh, that hurts, or I've got an itch for something, right? So that's kind of an interesting corollary, being this part of the limbic system instead of, say, primary somatosensory cortex. It's also worth noting that the insula gets inputs from many of the other sensory cortices, right? So if we go back one, you'll see that the olfactory bulb coming in here is right next to the insula. So primary olfactory cortex is right there, gustatory inputs, meaning taste, and then also somatosensory, auditory, all these regions are nearby and sending signals to the insula, which puts it in a great position to integrate these internal sort of sensory signals and some of these signals about the external world and combine those into one sort of representation. And so why is that useful? Well, being aware of what's going on inside your body and how that's reacting to the things going on outside of your body are very important for certainly emotions, but also establishing some sense of self. How do I feel right now, right? And there are people that also have theories that argue that this is some part of the basis for how we are conscious, right? Is basically this: we experience the world as a single entity, so we have one unitary experience of what's going on right now, right? And so having one region that has access to the internal and the external signals and can create that unified representation might be something of use there. And it's also important that, sometimes we want to pay attention to what's going on in our own bodies and minds versus what's going on externally. And the insula, some imaging has shown that the insula is involved in sort of switching between those two different states, right? So either paying attention to what's going on in my own head versus what's going on out here in the lecture. So what's going on wrong in the insula? Tons of things. There are many, many disorders that have been linked to the insula in recent years, now that it's kind of picked up some attention. So here are just a few highlights. One paper by my friend and colleague, Dr. Knight, is focusing on lesions specific to the insula, which are incredibly rare. Based on the vascular tree you've seen, it's not like there's one main artery that feeds the insula and not the other stuff. So these were very rare patients that they got a hold of, and they basically compared their ability to assess other people's pain. So empathic pain, right? Empathy. And they were not able to correctly judge other people's pain, right? So if the insula is pain processing, then this also shows you that socio-emotional status, right, where you're not able to process others' pain. There's a really interesting phenomena in the seizure world, in the epilepsy world, where there's this rare type called ecstatic seizures. I'll let you kind of read the quote here, but there's some really interesting sort of reports for, again, the semiology. What are the symptoms? What are you reporting? What do you feel like when this seizure is happening? And again, I'll highlight here the enhanced sort of self-awareness, right, and some very interesting other patterns. And they've noticed that a lot of times these ecstatic seizures are coming from the insula. And so there's also, if you go back and look at some of the slides from previous lectures on CTE, then you'll see that there's tau deposition in the insula, not immediately, but within sort of the mid to late stages. And if you start Googling around, use Google Scholar to search the academic literature, you'll see the insula being implicated in all kinds of other disorders. Either abnormal activity or abnormal connectivity, meaning relationships to the other brain regions involved, in anxiety, autism, schizophrenia, frontotemporal dementia, and a host of other sort of disorders, right? So it's unsurprising that a region that has this sense of self and emotions and all these interesting functions goes wrong in some of these things and various disorders. So just to kind of wrap up the reasons that I think people don't tend to pay much attention are that, again, out of sight, out of mind, right? It's buried deep in the Sylvian fissure, so people don't tend to go there much. And actually this Corbinian Brodmann, one of the people we mentioned at the very beginning for developing this cytoarchitectonic atlas that parcellates the cortex into different regions based on how the different layers have their cell bodies distributed. If you look at the section slides, there will be little BA this, BA that in the lateral frontal or the orbital frontal. He didn't even give a number to insula, right? So going back for a long time, people didn't really care. But methodologically, it's very difficult. Actually, fMRI has the spatial resolution to see the insula, and it's very commonly reported in many different studies, regardless of whatever the task is. Is it decision-making? Is it listening or speaking? Whatever it might be. But because it's so commonly activated, it makes it really hard to interpret. And then the scout-based techniques, EEG and MEG, again, think about where the dipoles in the brain are and how those signals would propagate out to the sensors on the scalp, right? If you're buried deep there and you have this convoluted skull surface where the dipoles are all going to be pointing in different directions, and you have a lot of tissue between that and the sensor, very unlikely that you'll actually be able to say with confidence this signal came from the insula. And then in terms of animal work where they can go just implant electrodes, there's a lot of tissue between the sort of surface and the insula, right? So you'd have to be very dedicated and decide, I really want to go for the insula in order to kind of make that decision with this animal, and so that makes it a less attractive target. So people tend to ignore the insula, even though I would argue they shouldn't. And so that's one of the reasons that I like to study the insula.
You show the next slide.
Yeah, so speaking of studying the insula, this is an x-ray of a patient that has these stereotactically implanted electrodes for epilepsy treatment. And so they're basically recording from these regions to try and figure out the seizure onset. And you can see that from this view, you have no depth, right, to see where all of these are relative to each other. But there's a couple here that you can see are targeting the insula. And so this gives us the opportunity to record the electrical potentials from the region itself, right, which gives us the temporal resolution that fMRI doesn't have, so we can resolve some of the ambiguities in that literature. And we're recording right there, so we don't have this problem where the signal here, like, it's really messed up by the time it gets out here. So we have this really nice opportunity, and if I'm lucky, I'll figure something out about the insula before my PhD is over. Oh. Where's this thing go?
All right, so now you're, and because of that presentation, I had to revise the limbic system 2018 to that, so thank you, Colin. It's an interesting area, that's for sure, and it's huge, and not much is known about it. So, all right, perfect. All right, so we're going to switch to the next topic in the course, which is hemispatial neglect. And as I mentioned at the end of the last lecture, as a first pass, if you just associate the left hemisphere, particularly in right-handers, with language, you can associate the right hemisphere with the allocation of attention. So I've been interested in hemispatial neglect really from almost the beginning of my career because I find it one of the most fascinating syndromes. And I'll show you some patients and you get a good feel for it. Now, if I look out at this room consciously, I see the whole room. If I was a hemispatial neglect patient, I would say I only saw this part of the room. But interestingly, things that occur in that part of the room that I don't consciously perceive might affect my behavior. For instance, there's a woman there with a cow shirt on. If I'm a neglect patient, I didn't really see it. But it might change my behavior, and I might go to the cow store to buy a shirt for my grandson. So this is this incredible distinction between your conscious perception of the world and unconscious activity that actually influences your behavior very strongly. So this is a very fascinating neurological syndrome. It gives you the key into these two dichotomies of processing, the world and your internal representation of the world, and how things that you don't consciously see might really influence your behavior. Another example might be you're going home, and you're walking near you're walking on one of the streets here, I don't know where all the shops are now, that sells camping equipment. But you're on your phone and you're going, you're just focused on your phone, but of course the visual stream from the stores is coming through. You go past the stores, and one of them's the camping store. You get home, put everything away, then a little bit later, you don't know why, you go to your computer and you open up things related to backpacking equipment because the store unconsciously primed you. So this is going on all the time in your world. So let me show you a patient with hemispatial neglect. Oh, one more thing. Another fascinating part of the syndrome that has a very interesting link to Freudian theories of psychology, not that Freud had any biological theories, is when you see these patients and they don't see the left half of the world, and typically their left side is paralyzed because you typically had a big right middle cerebral artery stroke, or at least a big chunk of it, and you say, what's wrong? They say nothing. Or they change the topic and say, well, my stomach doesn't feel good. And you take your hand, you put it in front of them, and you say, move your hand. You take their good hand, they move it. You put the left hand, say, move it. They can't move it. You say, why can't you move it? They say, I don't know, and they change the topic. They deny they have a problem. And this is one of the characteristics of people in the psychological literature. Started with Freud of basically this idea of a hysterical conversion reaction. You see someone with a neurological problem and they deny either having it or knowing why they have it. So it's very, very interesting. So this is a gentleman who had a big right middle cerebral artery stroke. He's being examined by my good friend and longtime colleague, Bob Raffel. So what you saw is Bob approached the gentleman from his left side, and the man had no orientation to him, nothing. It was like Bob wasn't there consciously. And as soon as Bob just moved the dollar bill to the other visual field, the patient automatically oriented. That's basically the kind of things you see with these patients. The left side of the world does not exist. These are a summary of the kind of things you typically see. The first one's really very important because this really gets into hardcore brain organization. The right side of your brain wants to drive your body to the left. Your frontal eye field's on the right. Want your eyes and body and everything to go here. The left side frontal eye field and the left other parts of your brain want your orientation and your body to go here. Right? So they're in constant balance. But when you have these patients with hemispatial neglect, because they've lost these control centers in the right side of the brain, when you walk into the room, here's how they look. They're looking to the right, and their eyes are to the right. And you don't have to do anything else. You know they've got hemispatial neglect because they've lost this control system to push their eyes and keep their eyes and body in equilibrium. They don't orient to left-sided stimuli. You saw that with Bob's patient. They don't search the left hemispace. I'll show you examples. They deny illness, which is just incredible. They also have a very interesting affect. They're what's called aprosodic. What's aprosodic? Prosody is the affectual, emotional tone of what you say. So I could say something like this: go to the store, go to the store. It has the same semantic content, and one time it's neutral and one time it's angry. So that's very normal. We extract that in our everyday interactions, and actually that's dependent on the right hemisphere. And we didn't talk about this technically under the neurobiology of emotion, but it is part of the neurobiology of emotion, that the ability to perceive the prosodic content of what someone's saying to you and the ability to output speech with prosody is impaired after a right hemisphere lesion. So the patients talk in a flat, monotonic voice. They're not hypophonic like Parkinson's. They're just flat and aprosodic. This is a very characteristic presentation. And then motor and persistence, which bedevils first-year residents and sometimes certainly med students, because they try to examine the patient. They go in, the med student goes in first, has to get a history, do their best exam, then the intern, then the resident. So these patients often, when you say to them, close your eyes, Mr. Smith, and keep your eyes closed, the patient does this. Close your eyes. Please keep your eyes closed. They can't stay on task. It's called motor impersistence. And it's often misinterpreted as the patient not cooperating. It's actually a classic sign of patients with big right hemisphere strokes and hemispatial neglect, motor impersistence. So this is what you see. So let's take a look at the causes typically. We went over vascular in some detail earlier in the course. And basically, the areas that you're going to see are going to be really critical for hemispatial neglect are areas that are, the blood supply is coming from the middle cerebral artery, which you see here quite clearly in red. Not the posterior cerebral, usually not the anterior cerebral, although sometimes rare cingulate strokes can have hemispatial neglect. So I don't want to take it totally out, but it's really in general lesions in the middle cerebral distribution. They look like this acutely. Here's an acute CT. This is a scan with a contrast-enhancing lesion here. On an MRI scan, see this is just an acute stroke. It's involving the frontal eye fields, which are about right here in your brain, sitting right about there. And this is a chronic one that has knocked out the back part of the brain on the right side, the temporal parietal junction. So these are the two big branches of the middle cerebral, the front and the frontal and the posterior branch. That's a chronic one. You can see all the tissue's been resorbed. So this is to point out that most of the cases have lesions either in the frontal eye field or the temporal parietal junction or both, if it's a big middle cerebral lesion. That accounts for many, many of the cases that you see of hemispatial neglect. So now let's take a look at another interesting phenomenon. I'm going to show you a couple examples of this over the course of this lecture. Basically, these patients not only, if something transiently happens in the field, contralateral to their stroke, they may see it. And then if you present the stimuli to the patient, I'm the patient, I got a right hemisphere stroke, and I say, Mr. Smith, tell me which hand moves. They go right, left, left, right, 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 left, left. What did I do there? What did I do? What was the key thing that was abnormal in my response? Anybody? Yeah, what? When you present double simultaneous, the stimulus in the neglected or, quote, extincted field disappears. And it holds across modalities. You get the same effect in tactile when you touch. Patient will say, patient has a right hemisphere stroke. You touch him. Touching is going to be movement. Left, left, right, left, right, 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 left, left, right. That's extinction. Okay? All right, so let's take another look at my friend Bob examining another patient.
Look at me. Which one? Right hand.
Good. Which one?
Left hand.
Good. Look at me. Good. Right at me. Ready? Which hand?
Left hand.
Extinction.
Good.
See it?
Which hand?
Right.
For you. Look at me again. Which hand? Great.
Classic
Again.
extinction.
Right.
Again.
Hand.
Good.
Okay, so extinction often lasts for a long time, and depending how you test for it, you might even see it a year post-stroke. The acute syndrome, with the turning to the right and the body to the right and the severe not paying attention to anything on the left side, gets a fair amount of recovery in the first couple of months. It may never go back to baseline, but it almost can. And what that tells you is the attention system's a little more distributed, because the same big lesion in the left hemisphere, as we'll talk about later in the course, where you get a severe aphasia, that's not going to show tons of improvement at a year. So neglect has a better recovery pattern than aphasia, but it's still a severe chronic problem in many patients. It's certainly acutely. The other thing that you see in these patients, which is really very characteristic of them, is this phenomena. Okay. So what did she do? Right? She jumped away. Right? Because I violated her social space. If I get this close, you're okay. Not so okay. But there's this social space. I violated it, and she jumped. That's what you do. These patients don't. So they really are neglecting even people coming close to them, which you normally would jump away, like we just saw.
Mr. Ward?
Yeah.
How you feeling?
Notice he doesn't orient his head to the left. He stays looking over to the right.
Listen, can you see me over here?
Mm-hmm. Yeah.
Where? Can you look at me?
Mm-hmm.
Oh, okay. There you go.
See, he's just bringing him into focus. He picked him up when he turned his head. Now, the bedside test for this is really simple. Actually, you can tell clinically, right? You've already seen what it's like. You can diagnose it. Clinically, what you do at the bedside, just to have some documentation of the extent, is you do the Albert's line cancellation test. This is a really sophisticated test. It costs 1/1000th of the amount of money of an MRI scan, but it's pretty helpful. You put a piece of paper on the front, in front of the patient with all kinds of lines on it. You give them a pencil, and you say, "Ma'am, cross out the lines." Okay? They cross out the lines on this side, and they don't cross them out on this side. You say, you really missed some. This is a severe acute case. You say, can you check again? The person recrosses out these and doesn't go over to here. If I put a line in front of the person, let's say that long, and I say simply, please take the pen and cut the line in half. You should cut the line in half here, right? But they don't. They cut the line in half over to the right because this part of the line is not being consciously perceived by them. It is not a primary visual problem. This is really important. This is a problem with allocation of attention. And how do I know that? I'll show you that in a minute. I'm sorry. I want to say one more thing on the Albert's line bisection that I didn't go over. If you really force the person's eyes to go from the right a little bit towards the left, you can put ice calorics in their ear and it dries their eyes. You'll actually get a little improvement in the Albert line cancellation, but still, you'll never get it back across to the midline. The important thing really is, the important thing is actually this particular here and this particular Albert's line cancellation task and the line bisection task. So let me show you about a 2.5-minute tape, which shows a lot of these features in a gentleman I saw at the VA. He's had a large right hemisphere stroke. He's about 2 months post. He's in a rehabilitation unit. He's in front of a big room, and I'm examining him, and the first thing I'm going to ask him to do is point to everybody in the room. And what you'll see, he shows complete neglect of the left side of space. He comes over to here, and nobody else exists. It's a computer, I think it was a computer programmer. Yeah, nice guy. unfortunately.
Can you do me a favor? You're sitting here in the room. Can you just point out some of the people in the room? Do that for me. Point to the people in the room.
I mean, anyone?
Yeah, just point to everybody you see. Just go through and point to people. Okay. Yeah. Who else? Yeah. Yeah. Great. Who else?
Definitely you.
Definitely me. That's unfortunate for you, but me. Okay, so I want you to go all the way through and point to everybody you see. Right?
It doesn't go past the midline at all. All of you in this conference, this clinical conference, don't exist to his conscious world. And then I'll show you what I do with a little...
All right, great. So I think he's already shown you clinically that he's got hemispatial neglect because he knows he's got the problem. He didn't implement the rule of doing a search, and he basically pointed to everybody on the right side of the room, which is not what you see with someone who just has a hemianopia and they search. Now, if I tell you, who's the last person you see here? Point to the last person you see in the room, on this side of the room. Who's the last one you see?
Young lady back in the blue.
In the blue? Okay. All right, good. Can you now scan the room, move your head around, see if there's anybody else in the room? Can you move your head? See anybody else?
Right.
Okay, let me do a couple more things. Can you see anything? Tell me if you look at me. Anything? Tell me when you first see something.
Yes.
You see anything here? Look at me. Anything? Nothing?
I see you.
Okay. You see it here? See my hand moving?
Yes.
Tell me when it goes away.
So just to stop for a moment, you could see he's got the classic failure to search until I prompted him and had him search. In an acute, he's 2 months post, so he's actually much improved. In an acute case, their head would stay locked. They wouldn't even be able to do that. The other thing this gentleman has such severe problems with the left side of space, it actually looks like he's got a left hemianopsia from a calcarine cortex lesion, but he actually doesn't. But his deficit in visual perception consciously is so severe that I can't get him to even respond to elemental stimuli. But I wanted to mention, if you take patients who have a posterior cerebral artery stroke and have a hemianopsia, so that if they're looking at this, I'm looking right at you, and I do their visual. If I have a lesion here, they're going to see everything to here, and they're not going to see anything on the right side of the room. But if I ask them to point to the people in the room, they're going to search the room, right? They're going to find everybody, so they're not going to show hemispatial neglect. They have to be, when you have a patient with a hemianopsia, you need to be really careful if they're going to drive. They have to just they need to be really aware to search. Because if you're not occasionally searching with a hemianopsia, that part of the world is not there, right? Because you've got damage to your primary visual area. So let me just finish this little clinical vignette.
Can you see it there?
Yes.
He's got his eye gaze over there. Can you see it here? Anything here? No. Okay. Okay, close your eyes. What number? Can you tell?
No.
How about this one?
1.
Good. How about this one?
2.
Okay. How about on this side? Can you tell here? What number is this? No. Here. So what I want you to do is close your eyes and tell me if I touch your left hand or your right hand. Okay? Here we go. Ready? Which hand?
Right. Left. Left. Right.
Okay, now I want you to tell me if I'm touching your right hand, your left hand, or both hands. Ready? Here we go. Which hand?
I don't know.
Which hand?
Left.
Good. Which hand?
Right.
Which hand?
Right.
Which hand?
Left.
Which hand?
Right.
Which hand?
Right.
Take your red pen and put a mark through each one of those blue lines.
Each one?
Yeah. Yeah, well, just hit them each one, okay?
So he's way better than the initial slide I showed you of someone very acute when they're getting this much of the world. All of this is gone.
Excellent. Okay, pretty good. He's still neglecting part. This is the classic Albert's line by. Okay, so you saw that gentleman. He's about 2 months post, and he continued to get better. I mean, he's still. If you check him for extinction now, because he's got enough perception in the left side that he recognizes single stimuli. He has residual of both visual and somatosensory extinction, but his aprosodic affect is improved, and his attention capacity is improved. And I want to reiterate, this is not a sensory problem. So, way back in the course, when we were talking about visual fields, right in the beginning, we talked about the visual field projection. The left calculin cortex takes care of the right side of the world, and you can have a little lesion in there, which produces a little deficit in the right side of the world. You can get the inferior bank of the calculin cortex, V primary visual V1, and you get a quadranopsia, which means a quarter of the field is gone. Or you could take out your whole calculin cortex, almost always from a posterior cerebral artery infarct, and you have a hemianopsia. And as I mentioned to you, this is a patient with dense hemianopsia, and here's the Albert's line cancellation test in someone with neglect severe, and as we showed, they only cancel lines on the right side of the paper, but the patient with hemianopsia actually, because they don't have an attention disorder, they scan and look, and they actually get all the stimuli. So that's a good example of it not being a sensory problem. Interestingly, for those deep into the world of how you allocate attention, these are neglect patients, and this is actually from some work by Luria. These are neglect patients where they're shown a specimen. Right? They're shown 3 little stick figures. And all they're asked to do is copy the 3 stick figures. That's it. Right? That's not very hard. So what they do is they show hemispatial neglect, right? This little guy here is not drawn, and half of this person is missed. Pretty interesting. But if you know, so that's spatial neglect. But if you really notice carefully, what else is wrong with their drawing? What is missing? And what? Yeah, the first guy has no left hand. So it's not just spatial. It's actually components of object. So depending on where you were in the recovery, initially I wouldn't notice anything, but I might then notice part of this, and it would come back. The left guy would appear, but even in the good field, there may be some problems, right? I may be not properly allocating attention to all these objects, so I might only see not perfectly all of you. It's very interesting how this attention system works, both object and spatial. The clinical part that you see, that you see in all the textbooks is, for instance, you have them write on a piece of paper, and they don't write on the left half of the paper, right? You see that all the time. This is the classic one. You basically tell them to draw a clock and set the time to 6. And they basically take the 12 numbers, put them on the right side of the clock, and set it correctly to 6, as if this left hemicircle of the clock doesn't exist. But activity in the left side of the face, a la this woman's cowl shirt, does affect your behavior unconsciously. And I'll just show you a little bit of that. Very, very fascinating area of research. You have the patient look at these 2 houses on top of one another. And you're getting them to fixate here. So they're looking here, you flash the 2 houses, and you say any difference between the 2 houses. Now, of course, you say there's a big difference. The patient with hemispatial neglect, since they don't consciously see the left side of space, says, no, there's no difference between the 2 houses, okay? Because half of it is not consciously in their mindset. But now, if you do one simple little question, and you say, which house would you like to live in? They always pick this one. And then you ask them, why did you pick that house? They have no idea. They have no idea how this unconscious process was. It's pretty cool. It's kind of, you think you're totally in control.
But as Facebook knows, you're not. And they're taking advantage of all of you. I think I'm going to start a new company. What should we call it? A free, I don't know, non-Facebook. Shouldn't say that. Actually, yes, I should. I mean, 87, the Russians got 87 million pieces of your information. Luckily, they didn't get mine, because when Facebook first came online, I had a freshman seminar. The freshman said, Professor Knight, can we have a Facebook chat room? I didn't even know what it was. I said, no. And they said, why not? I said, well, how many friends do you have? The average number of friends for a group of 15 freshmen was, I think, 520. And I said, I've got 7 friends. They're all on my phone. One of them's getting a stem cell transplant for lymphoma and may be dead. And then I'll only have 6. And they left me alone for the rest of the semester. But Russia doesn't have my information. Ha ha. Yes? Yeah. Yes, they were. Right? So they're kind of transforming information internally represented in the left field and squishing it over into the other field. Right? They know it's there. You ask them, how did that happen? They wouldn't know. I mean, the answer would always be, what? Okay, so, which house is dangerous? Duh, you know the answer, right? This one. Again, why? I don't know. So this is a classic example of processing, unconscious processing in the neglected field in patients with this very classic neuropsychological disorder. Who's been to Milan? Anybody been to Milan? Yeah? Okay. Tell me about Milan, the cathedral area. Do you remember anything about it? Tell me what was there.
It's like a big square, and then there's 2 streets that cross this way and that way, and stores.
What kind of stores? I know all the stores because my wife is from Milan. I've been to. I'm an expert on leather stores. Go ahead. I'm sorry. Go ahead.
A lot of shopping versus clothing stores.
Yeah, tons. And then at one end there's a big cathedral, right? I'm glad that you remember the shopping stores before the cathedral. The cathedral's a lot better. No, I'm only kidding. I'm sorry. Don't pay any attention to me. Okay, so that's the cathedral at one end, and we just heard, there's stores along each side. Milanese know where the stores are. It's like you know where the stores are on Center Avenue, right? They just know what's there. At the other end of the piazza is a big government building. One end the cathedral, one end the government building. So a very clever Italian neurologist, Eduardo Biziak, did a really simple study. He took patients in the hospital with hemispatial neglect, and they're in a wheelchair or in their bed in the hospital, paralyzed on the left side, hemispatial neglect, and he says to them, okay, what I want you to do mentally is put yourself on the steps of the government building and tell me what you see. Look at the church, and now report everything you see. And just like you can vaguely remember, they know all the stores on this side. So they say, this is this, and this is that, and this is this, right? So now you just do the most simple manipulation. You say to the patient, what I want you to do is put yourself at the other end of the Duomo, at the other end, in front of the Duomo, and look this way. And now tell me what you see. And they report all those stores. Now think about that for a minute. That means all the stores were there, per your question, where the numbers kind of were. They're all there, right? Because depending on their internal mental representation, where they're looking, they can report every single store, depending on whether they're looking in one direction or the other. Now, we're not as cultural as the Milanese, so this is my bedside test for hemispatial neglect. Now, unfortunately, you need to know baseball. Not everybody does. But if you take a patient with hemispatial neglect and you don't show them this, you say, what I want you to do is make believe you're the catcher, and I want you to mentally look at the pitcher in the center field, or look here. Tell me what players you see. They report the pitcher, the center fielder, the right fielder, the second baseman, and the first baseman. Now you say, just like in the Milanese, very elegant study, very, very nice study, You say, okay, now you're the center fielder. Look into the plate. Tell me what you see. And just like in the Piazza del Duomo, they report the pitcher, the center fielder, the shortstop, the third baseman, and the left fielder. So this syndrome is a remarkable deficit in the internal representation of space and even facts. Very, very interesting syndrome. Now, there's a bit more I want to go over in this syndrome, which we'll finish up next Monday. I'm just going to show you one other feature that you often see in these patients. If I ask anybody, can you just tell me, what do you see there? What when you look at that, what do you see? Yeah. Yeah, an S composed of E's, right? That's a standard figure. If I show this stimuli to a patient with right hemisphere damage and neglect, or to a patient with left hemisphere problems and aphasia, you get a remarkable split in their response. And that is, here's a stimulus. It's an M made up of Z's, and it's a triangle made up of rectangles. Here's the patient with right hemisphere damage. They see all the details, because they draw all the little rectangles, and they draw all these Z's going every which way, but they don't get the global aspect of the picture. They miss the M, and they miss the triangle. If I show the same stimuli to someone with large left hemisphere damage involving typically the temporal parietal junction, the patient draws an M, perfect M, a perfect triangle, but misses all the details. And this is another thing that is not well understood, but this tremendous difference of your right and left temporal parietal junction for global versus local processing. Global means this is the room full of students, and in each room the details are an individual student. Okay? So you're an individual student. And now I look at you, and now you're the global aspect. My right hemisphere is controlling that. The details of you, what you have on, etc., are the local aspects. And you could go even further. You could switch your frame of reference to this woman's face, and only her face would be global, right hemisphere, and her eyes and other spatial features would be detailed. You could go all the way down to the eyeball and have the eyeball global and the pupil local. And you do that rapidly. You do it very fluidly as humans. You don't even know you're doing it, but you're constantly adjusting your attention between global and local features. So I'm going to stop there, and we'll restart. In the next class and finish up hemispatial neglect. Rock and roll.